of all, welcome. Thank you guys for coming to assist with the Casper Fire-EMS Department's EMS training for May. With it being National Stroke Awareness Month, we thought we would try to partner with Banner Wyoming Medical Center and meet with a neurologist and one of the neurology nurses and just have some discussions on strokes and other neurological emergencies. So if you guys each would spend a minute or two just introducing yourself, I think that would be great for the guys to know where your experience is coming from. Sarah, would you like to get us started?
Yeah, hi. My name's Sara Kemper. I'm a nurse at the hospital. I've worked there for about 6 years, 4 years in the neuro care world, and then almost a year here with Dr. Wheeler, specifically working with stroke patients.
Awesome. So in your position is stroke coordinator, correct?
Correct.
So
yes.
Every kind of the way you fit into this is every single pre-hospital stroke patient we see, you end up kind of attaching to them and going through their charts and doing QA/QI, making sure that their care is appropriate, right?
Absolutely. We make sure that they get everything they need in hospital and then to go home with.
Awesome. Thank you very much.
Yeah, thank you.
Dr. Wheeler?
Morning, thanks. This is a great time to spread the word about stroke. My name is David Wheeler. I'm a neurologist. I've been in Casper for 18 years. Throughout that time, I've been the director for our stroke program at the hospital, which has grown to now encompass stroke care at 10 additional hospitals around the state through our telestroke network. And along with Sarah's help, we've been working hard over the last few years to try to improve the system of care for stroke on a statewide basis.
That's awesome. So I hadn't even heard of all that telestroke stuff. Does that just mean that you guys are consulting physicians for a lot of smaller hospitals throughout the region?
Right. So we cover emergency departments for specifically for 10 other hospitals that have telestroke equipment in their ERs that we own and operate on their behalf. So they, just like what we do here in Casper, when a stroke patient is on the way into the ER, they activate a code stroke in the field, and the team there in those local ERs will call through the regional referral center to activate a telestroke consult, and either myself or the other neurologist will get on the platform and be ready to help start evaluating that patient using the two-way audio-visual connection. This gives us the ability to look at their CAT scans in real time and participate in making decisions about whether or not to give TPA or not, and then whether or not to lifeline them to Wyoming Medical Center for a higher level of care if needed. Yeah. So that program's been up and running for 4-ish years, something like that. And this is actually it's our second effort to build a system like this. We ran a pilot program in 2009 through 2011 where we had 3 hospitals in our network, and that's really where we got the ball rolling back then. But it's been a very successful program. We're seeing an increasing number of patients, not just as consults, but an increasing number or fraction of patients getting treated with clotbuster medication. So more stroke patients are arriving in a more timely fashion as community understanding about the value of this treatment is spreading throughout those communities.
That's awesome. And that's one of the things we hope to do today is spread a little bit of awareness. I do have a follow-up question on that, and I can't remember, is Banner Wyoming Medical Center the only stroke hospital in Wyoming? So I would assume most of those kind of distance patients end up coming here anyways.
So Cheyenne Regional Medical Center is also stroke certified, but I don't believe they do thrombectomy, so we're the most capable center in the state right now.
That's awesome.
So,
It's great to have that resource here in Casper, and it's awesome that you guys are reaching out and spreading that knowledge and experience to other places in the region. Thank you guys very much.
Yeah, thank you.
Now, Sarah, I heard that recently you guys were awarded, get with the guideline, I don't know if you call it an award or a recognition for your stroke care. Can you tell us a little bit about that award and what it entails and what you guys had to go through to get that award?
Yes, so part of what I do for the stroke patients is abstract all of the data I can from their charts and enter them into national registries. So these things track, are we giving them the right medications at the right time? Are we doing interventions beforehand that they may need? And so we have to meet a certain target percentage on each metric in order to get these awards. So we were awarded the advanced, it's an honorable elite advanced with target diabetes, which basically means that we hit every single measure that we were supposed to, and really, and then some. Our team has done a really great job.
That's awesome.
So yeah, a lot of that involves real-time tracking. Dr. Wheeler rounds on the patients every day. I try to when I can. We talk with the nursing staff, make sure the patients have what they need when they're in the hospital instead of kind of backtracking later on. But yeah. That's
great. Do any of the metrics that you guys track and are responsible for involve first responders, such as the fire department?
Yes. So I would say every time that I track, we call it, door to needle, door to CT scan. A lot of these things wouldn't be possible if the patient didn't get here in a timely manner, or if Dr. Wheeler wasn't notified of the stroke beforehand. So I think, the fact that we can treat patients in a timely manner has so much to do with EMS.
Awesome. Well, congratulations on that award. Keep up the good work. We'll go into the roles of fire department personnel on the care of these stroke patients here in a minute.
Absolutely.
All right, let's jump into it. So first of all, what I wanted to start with this morning is recognizing strokes. And you guys can take these questions, whoever would like to answer them. I'm fine with whoever jumping in. The first question is, so what stroke screening would you recommend for first responders to use on a daily basis to identify stroke patients?
Sure. I think it's very appropriate to use the simplest and most widely recognized scale for recognition of stroke in general, which is the Cincinnati Stroke Scale. So we do strongly encourage competency and training with that, and it really ticks most of the boxes. Now, that particular scale, which you'll recall looks at facial symmetry, the ability to speak and understand commands, and the ability to hold the arms in the air, is very, very good at detecting strokes in the front 2/3 of the brain, but not as good at recognizing strokes in the back of the brain. So these posterior circulation strokes where symptoms are more likely to be problems with vertigo or dizziness or alterations of consciousness, those tend to get overlooked by the Cincinnati Stroke Scale. There's a slight modification, which is has a different acronym. It's called the BFAST test. So you guys have probably heard of FAST, face, arm, speech, and time. That's the equivalent of the Cincinnati Stroke Scale that we use for public education. If you add balance and eye movement to the front of that, it becomes BFAST, and that actually increases our ability to detect strokes in the posterior circulation. And I think that's important because those are by far and away the most commonly missed strokes. When a patient with posterior circulation stroke arrives in the ER, it's not uncommon for them not to be diagnosed as a stroke, and adding the BE to FAST, or balance and eye movement assessments, to your Cincinnati Stroke Scale can significantly increase the probability that you won't miss those strokes. So that's part one. Part two is in this newer era of stroke treatment, where we have the ability to treat strokes well outside the usual 4.5-hour window for clotbuster, we need to make some assessments as to the severity of the stroke. And for that, we have a whole bunch of tools, but we don't have yet any clinical trials evidence as to which tool is better than another. And so I don't have an evidence-based basis upon which to recommend one tool versus another. So examples are the C-STAT, which is the extension of the Cincinnati Stroke Scale, or the Stroke Van, which is a nice one because it's got a beautiful app that you can use on your phone. But what these basically do is they're kind of like BFAST, and if I come full circle on this answer, I think that BFAST kind of gets to both whether or not a stroke is present and also how severe that stroke may be. And the reason for this is if a patient has stroke symptoms with an unknown time of onset, but it's within 24 hours, they might be a candidate for treatment if their stroke is severe enough to warrant that treatment. So in the hospital, we use the NIH Stroke Scale score, which is a bit of a cumbersome tool, but is a really good way of deciding if somebody's stroke is severe enough or not. In the field, I would recommend BFAST or the C-STAT as a way of helping communicate to me, the neurologist, how severe the stroke is and whether we should activate a code stroke even though they're outside the usual time window for clotbuster medication. So I propose BFAST and or C-STAT as good scales to use here, but recognize that there are many other tools available, And and any one of them may be just as good as another. We don't know the answers to which one is best yet.
I'm sure we will though.
There are many trials underway, so you're 100% right. In the next few years, we'll get the answer.
Well, I can tell you right now, I bet you we use BFAST moving forward because we already use the FAST scale.
Yeah.
And I think you just knocked it out of the park from my perspective, just adding the balance and eye movement to that, because I had never heard some of those details about the locations of the strokes and how many we were potentially missing.
Yeah.
So can we go into a little bit more depth just on those findings, where first of all, what are you looking for in the balance and the eye movement? Because I've never been educated on that.
Yeah.
And then what is, like, a lot of our providers I think are relatively comfortable identifying obvious strokes when you have obvious facial droop, obvious arm drift, or slurred speech, or incomprehensible speech.
Yeah.
What are some subtleties that, so like minor strokes that we may be missing?
Yep. So you're it's 100% true that it's easy to recognize the big MCA strokes that we all know about, which are one-sided weakness, can't talk. The more subtle strokes that can include maybe just components of that, so difficulty moving the eyes past midline, for example, it can exist by itself, can be a pretty severe stroke, but can be a little hard to recognize if you're not actually looking for it. So we do recommend evaluating eye movements by having the patient track your finger up and down and side to side. And if they're unable to get their eyes past midline in one direction, then that's a really important finding that could suggest a severe stroke. So that's the B. The B would be a balance assessment. If the patient's not hemiplegic and could therefore, in theory, stand up, it's important to get them to stand up with their feet close together and see if they can do that with their eyes closed. A person with a cerebellar stroke, especially towards the middle of the cerebellum, may be able to do finger to nose testing pretty easily. You won't have any weakness, but as soon as they try to stand up with their feet put together and their eyes closed, they get super wobbly. If that part goes fine, you might have them just take a few steps, maybe one foot right in front of the other, kind of a drunk test type of thing. And if they're super unsteady on their feet doing that, that also can be a sign of a cerebellar or brainstem stroke.
Do they have to do the steps with their eyes closed?
No, eyes open. Eyes open, yeah. So,
and then I've seen it done both ways, but as far as the arm drift assessment goes, eyes closed or eyes open on that one?
It should be done with eyes closed. If they can't lift their arm with their eyes open, then it's not really necessary to take that test further. If they're obviously weak, then you don't need to have them hold both arms in the air.
And is that, like, the eyes closed thing, is that just because there's, like, if myself as a patient can see one arm drifting, I will try to compensate for, or what's the...
100% right. So what you're testing there is not just strength, but also sensation in the arm. And so by closing the eyes, you're taking away that visual feedback that would allow a person to know that their arm is moving, even if they can't feel it. So if they close their eyes and the arm starts moving, especially if it's going up or around to the sides, then that's an indication that they're not having good sensation in that arm, which is a different type of stroke, maybe just as important, but a different type of stroke from the more typical pronator drift where the arm twists and goes back down.
Awesome. So again, Kat, like, what is enough in some of those changes? Like I say, the obvious things are obvious, but what is too much or not enough arm drift or speech impediments or anything?
Yeah, so that kind of gets to the goal of the whether or not to activate. What are we trying to do here? So we're trying to identify patients who might benefit from acute treatment, either clot buster if they're within the time window for that, or clot removal if they're within 24 hours of their symptoms starting. And so those decisions are based on whether or not it's a stroke, one, but two, how severe that stroke is. And so there's no right answer for that, because the impact of a stroke on any given individual may depend on their actual circumstances, like who they are, what they do for a living, what their hobbies are. So for one person, having a little bit of weakness in the leg may not be a big deal, but for somebody who walks for a living, that could be a complete game changer. Same with a little bit of slurred speech for a teacher, that might end their career as well. So there isn't a hard and fast answer as to what's bad enough to activate a code stroke from the field. I think that the right answer is if it looks like a stroke and it fits it's less than 4.5 hours, or it's less than 24 hours and it looks severe enough to be a potential thrombectomy case, then we would activate. And I think that can be a challenging, it's a hard clinical decision to make, which is why our neurologist made the decision a number of years ago to make ourselves available to the first responders for real-time conversation about what they're seeing and what we should do about it. And I can get into why that was hugely impactful for stroke care in our community, and it's something that I think we all need to be really proud of.
Mm-hmm.
But it's a reflection of the fact that these are not easy evaluations, not easy assessments or decisions to make, and it's better to make it as a team whenever that's possible.
Yeah, no, I remember when we first started doing that, and I thought it was a great asset to have the subject matter experts on
Right.
strokes available to us any time of day. So
Yeah, and Sara can probably attest to some of how much that improved stroke care and stuff like that.
Absolutely. Just even for, we were participating in the International Stroke Conference in February this year, and this is one process that really sets us apart from other hospitals. It's pretty much unheard of for, the EMS providers to be able to call a specialist and say, hey, what do we do? So it is something we're very proud of.
And when we implemented this, we immediately saw an improvement in our treatment metrics. So, for example, our door to neurologist assessment went from 15 minutes down to mostly 0 minutes. Even in the middle of the night, it's not possible for us to beat the ambulance to the emergency department. If we get that call while you guys are on scene, we can get up and get dressed almost as fast as you can get there. That in turn dramatically reduced our door to CT time from about 25 minutes down to about 5 minutes, and then reduced our door to needle times from about 40 minutes down to about 20 minutes. So when you lose 2 million brain cells a minute during a stroke, shaving 20 minutes off your treatment time is a gigantic improvement.
it's huge.
And as Sara says, was then unheard of. We invented this idea here at Casper, and it has spread across the country. And I'm not saying it was the reason why, but it's the same thinking behind things like mobile stroke units. So ambulances that are built out with mobile CT scanners and telestroke equipment in the ambulances, so that the neurologists are evaluating the patients in the field. And the next step, which we're starting to see happen around the country, is the EMS provider, which in these cases, in the mobile stroke units, usually an RN, is actually administering TPA in the ambulance as soon as the CT scan is done and the neurologist has assessed the patient. So that's sort of the next phase or the next iteration of this assessments in the field that kind of got started here in Casper about 10 years ago.
It's pretty incredible. Yeah. Nice work.
Thank you.
My follow-up question is, how many total brain cells do I have? Rough number.
10 billion or so.
10 billion?
Yeah.
And we're losing 2 million a minute.
Yeah.
That's a lot.
Proper flow.
I do think it's worth mentioning too, just because it is Stroke Awareness Month and we are trying to get the word out there, this is a huge reason why it's important to call 911. If you see someone having a stroke, or instead of trying to get a buddy to drive to the hospital, we can have everything in place and the team ready before the patient gets to the hospital, versus triage and then let's call the neurologist, then let's get the team in place. So
saving millions and millions of brain cells.
Exactly.
That's
Yes.
Awesome. So I think I have one more question on identifying strokes, which is based on some of those findings, like how, I don't remember if accurate is the right word, but if one of our patients has one of those findings, whether it's improper balance or eye movement or arm drift, how likely is a stroke versus I'd assume if they have 4 or 5 of those, a stroke is extremely likely. If they only have one of those, is a stroke still likely?
Yeah, so we actually have really good evidence just from FAST alone that a single abnormality on the FAST exam is associated with an 80% probability of acute stroke.
80%. So that's pretty high.
Yeah.
And I would assume multiple just takes that number even higher.
Absolutely, yeah. So now there are confounders to that. So if somebody recently had a stroke, representing with the same symptoms is going to look just as bad, but there may be some other cause for their stroke symptoms to be coming back. So there's wrinkles on the story in every case, but until we know more, I think it's always appropriate to consider the high likelihood that you have an acute stroke when you have one abnormality on those assessments, so BFAST, for example.
For sure. I think that rolls us right into the next question perfectly, which is, okay, we go out and we do our BFAST exam, we identify a possible stroke. What are some things that we can rule out in the field that may be kind of mimicking a stroke?
So first and foremost, and this is built into your requirements for in-field care, is checking the glucose in the field. So severe hypoglycemia and less commonly hyperglycemia can cause focal neurologic deficits that look like stroke. Another really common mimic is weakness after a generalized seizure. So that's referred to as Todd's paralysis, and can cause weakness on one side of the body that looks like a stroke. But if there's a history of a seizure just before that event, then acute stroke is quite a bit less likely.
Can I ask one follow-up question on that one? And I think you pretty much answered it, but like how recent after a seizure are we talking? Like immediately following a seizure?
That's right. It's in the immediate aftermath. It's part of their post-ictal state, and it's something from which they should begin to recover within the first couple of hours in most cases. But in the absence of any history that a seizure occurred, so you come on scene and somebody is down and has weakness on one side, and you don't know that they had a seizure, then we need to treat it as if it were a stroke.
Gotcha.
Same category of if a problem is the so-called hemiplegic or complicated migraine, which can look very much like a stroke. The symptoms leading up to it can provide us important clues. So obviously if there's a severe migraine headache, and then the gradual development of weakness on one side of the body, it's probably not a stroke. But we don't always have all that information, in real time while you guys are doing your assessments. And so you come upon a patient who's hemiplegic, you don't necessarily know that they had all the migraine symptoms leading into it. So again, we would activate code stroke and then hopefully get more information. That being said, we would rather give somebody clotbuster and then find out later it wasn't a stroke than the opposite. If in patients who haven't had a stroke, the risk to them of receiving clotbuster is relatively low. It doesn't usually cause problems other than minor issues like nosebleed or bruises and things like that. But in terms of risk to having a hemorrhage in the brain, that's a pretty low probability if there hasn't been a stroke. And so there's this concept of you have to treat a few stroke mimics in order to make sure you're getting most of the strokes.
Yeah. And I think that probably goes along with the life over limb analogy.
You're right.
So,
Absolutely.
for sure. A couple of our guys, or at least one or two of them, emailed me, and I wanted to ask about Bell's palsy. Okay, something that can mimic a stroke as well.
Mm-hmm. Yeah, so Bell's palsy is usually really easy to recognize and doesn't look at all like a stroke once you know what you're looking for. So the main difference is in Bell's palsy, the ability to move the forehead is diminished. So usually in acute stroke, even with a really severe facial droop, that patient can still raise their eyebrows, as you're doing for me, and you'll see the wrinkles forming in their head. So if you don't see any wrinkles on that side and they have a droopy eyelid on that side, or sometimes even it's so weak that the eyelid is hanging down, it actually looks like it's wider. So it's interesting, it looks like the other lid is drooping, but it's actually the weak side that's being pulled open. So if you've got all that on the same side as a downturned mouth, and especially if there's no slurred speech, no significant sensory changes, arm function is normal, then that's almost certainly not a stroke. So again, in stroke, facial weakness usually does not involve the forehead, so they can raise their eyebrows and they can usually close their eyes. The person with Bell's palsy has this peculiar thing when they try to close their eyes, the weak side won't close and you can see the eye rolling up. So that's a characteristic finding in Bell's palsy that makes it pretty easy to recognize.
Gotcha. I summarized that real quick for everybody, I think. Tell me if I'm missing things. So we do our BFAST scale, check a glucose, rule out diabetic issues, ask about seizure history, ask about migraines, history of migraines, and see if they can raise their eyebrows for them, or at least pay attention to the
Think about that as a mimic for sure.
Yeah.
And that'll get us, hopefully, the vast majority of strokes identified.
I would think you're not going to miss very many if you do that assessment.
Awesome. Awesome. So hopefully now we know how to identify them.
There you go.
Sarah, let's move back to you a little bit and
Yeah.
talk some more, get with the guidelines.
Mm-hmm.
So can you go into a little bit more detail on some of the guidelines that maybe affect the EMS? You mentioned some door to needle, and I don't know if they do a first medical contact to needle. What are some of those times, and how can we improve those times for you guys?
Well, honestly, a lot of the times that I track don't really start until the patient hits our front door. So the most important thing is just that they can get there within an appropriate time for us to treat. I think one of our goals is to have you guys contacting Dr. Wheeler within 10 minutes of seeing the patient. But otherwise, as long as they can get to our door pretty quick and then we're in place and you guys have activated Code Stroke and communicated with Dr. Wheeler, everything past that is pretty smooth.
Awesome. So identification and then notification.
Yep,
The two biggest things.
that's absolutely the key.
What are some of the things that we can actually do pre-hospital that kind of help you guys out? I don't, as far as like meds or IVs or anything like that.
Absolutely. So we'd like the patient to try to have 2 IVs in the AC if possible.
Does it matter which arm for
nope.
you guys?
Nope. And we
Same arm, opposite arms, or just two?
Just 2.
In 2 anywhere. In
Opposite
ACs.
sides is nice.
Opposite sides
They have
is
to
nice.
be 18 gauge or larger.
Okay. Is that for the contrast
Yes.
Mhm.
that you put in?
Yes.
Okay.
Same reason why we prefer ACs. It's better for the CT techs and the medications if it's in the AC. The other thing, we've talked about blood sugar. We recently have tried to encourage patients to come in trauma naked to the ER because of some unforeseen circumstances, just to keep the ER safer, and then that we can assess the patient on the move, because we don't put them in an ER room, gown them before we treat them. They go straight from the gurney to the CT machine. So that's one thing that we've recently encouraged, is to either strip them down or find out that they've got nothing on their person at the time.
Yeah,
What else?
the EMS director has asked that trauma naked be a new standard of care for code stroke activations, and so education on that should be forthcoming. And that is specifically to try to keep weapons from accidentally getting into the ER setting.
Gotcha.
The other in addition to placing IVs, it's also helpful if EMS providers are able to draw a panel of rainbow bloods for us to deliver on arrival. And then once we get to the ER, we need you guys and the patient to stop in our pit stop area. So that's where we weigh the patient on the gurney. You give us, as the team assembles, you give us the quick overview of what's happened, and then we hold there until the ER physician and the neurologist have determined that the patient is clinically stable enough to go direct to CT, and we get an armband on them so we know who they are and can put orders in on them. So ideally that just takes a couple minutes, but we do want to hold in that space until all that stuff is done, and then we'll go straight to CT. We'll get the patient on the gurney, and then one of your team could take on the CT gantry, and then one of your team could take the gurney back to the scale, get the empty weight so we can calculate the patient's weight.
Because all those meds are weight-based, correct?
Yeah, the
Yeah.
clot
Pretty
buster
specific
medications.
dose.
Yeah.
Awesome. So really no meds then?
Technically, labetalol is indicated for treatment of severe hypertension. So if a patient's blood pressure is greater than 220 over 115, we may ask that you give 1 dose of labetalol in the field on the way in. And then, since we're talking about strokes and stroke mimics, if a patient has a seizure, of course, administering benzodiazepines in the field would be appropriate as well. So I'm not sure what you guys are carrying, but we've got protocols for diazepam, Ativan, or Versed, whichever you have on board.
Yeah. Just for your guys' knowledge, the fire department doesn't carry any controlled substances right now.
Right.
Wyoming Medical Center does. And I don't remember off the top of my head which ones they carry. I know they used to carry all 3.
Right.
I don't know if that's still current. I know Versed is our first line.
Versed is great because you can
using.
administer it intramuscularly, and we have recent evidence showing that it's the onset to benefit is faster than either Ativan or Valium. So we would like Versed to be the standard for all patients.
Perfect. So we need to recognize it, begin transport right away, get our IVs while we're en route, right? Save a little bit of time, a couple million brain cells.
Yep.
And then I wanted to ask about vital signs. Are there any vital signs? I mean, off the top of my head, I would want to do a 4 lead to at least see what their heart rhythm is. And then are there any vital signs that would be extremely important for you guys to know and tell us that it's a critical patient?
I need to know blood pressure, heart rate and rhythm, oxygen saturation.
Okay, and I would assume, since you mentioned beta-lol, like you say, hypertension is one of those things that takes that to the next level.
Yeah, so we typically wouldn't treat unless that blood pressure was well over 220. But in those cases, lowering the pressure to less than 220, it can be life-saving.
Gotcha. Awesome. I think now it's important we've talked about how to recognize strokes and how to treat them in the field. Let's go just into a little bit more depth on what strokes are and the difference between the two. And I think everybody out there should be aware of the 2 types of strokes, ischemic and hemorrhagic.
Okay.
But could we just go into a little bit if there's any different treatment for us, and then kind of what you guys may do differently in the hospital setting for those 2 patients?
Sure. So 2 types of strokes, as you mentioned, hemorrhagic and ischemic. Ischemic strokes are much more common. They account for 90 to 95% of all stroke presentations, with hemorrhagic being the much smaller group. So we've covered, recognition and treatment of ischemic stroke, I think, pretty well. So let's talk a little bit about hemorrhagic stroke. So hemorrhagic stroke treatment is quite different from ischemic stroke. You would never give clotbuster or any blood thinner in that situation. But we don't have a reliable method yet to distinguish one from the other in the field. Mobile stroke units can do that with CT scan, and there are emergent technologies using non-invasive techniques such as ultrasound, which may also help us to distinguish between them. We don't have that available yet. There can be a couple clinical clues that are helpful in guessing which is more likely. So people with hemorrhagic strokes their symptoms don't start very, very suddenly. So rather than going from one moment to the next of having complete paralysis, a hemorrhagic patient may evolve over several minutes. So they may first complain of headache, and then dizziness or nausea, and then they might sort of have a decreased level of consciousness, and then they might slump over from weakness on one side, and that might take 3 to 5 minutes. So if you have a witness to the event who can give you that level of detail, those are clues. The hemorrhagic stroke patient is much more likely to have a decreased level of consciousness than is the ischemic stroke patient. Most ischemic stroke patients are going to be fairly awake. Now, they may not be alert and following commands, but their eyes will be open and they'll be looking around, whereas a large hemorrhagic stroke patient might be somnolent and maybe not protecting their airway as well. Vomiting, sometimes forceful emesis is much more common in hemorrhagic stroke than ischemic stroke. And then blood pressures are usually significantly higher in hemorrhagic than ischemic stroke. So in those patients presenting with their blood pressures over 220, there's a little bit higher chance that's a hemorrhagic stroke, and beginning to lower their blood pressure in the field can be life-saving for them.
Good to know.
And then this is why we ask the question about medication history. So if they're on blood thinners, for example, that increases somewhat the probability that their problem is hemorrhagic rather than ischemic.
I think the time thing that you mentioned as far as hemorrhagic strokes maybe being not necessarily slow onset, but not instantaneous, makes sense in my head, but let's make sure I've got the idea right, that the ischemics can be instantaneous because there's no clot in your artery, and then just like that, there is a clot, and you've lost all downstream blood flow.
Yep.
In a bleed, or the hemorrhagic stroke, you're losing some blood, but you're still probably perfusing the tissues a little bit, and then as that artery bleeds, we're building up some pressure on the brain as well, which is what starts to impact those, and then it just takes a few minutes to build up enough pressure and to lose enough blood flow to cause the symptoms. Is that correct?
I think you said it perfectly, yeah.
Yep.
Awesome. What about the thunderclap headache symptom? I've heard that term before. What does that typically indicate?
Sure. So thunderclap headache is supposed to be the clue for all of us to think about a subarachnoid hemorrhage, usually secondary to aneurysm rupture. And so that intense global, or sometimes starting from the back of the head moving forward, but very intense sudden onset of headache that people describe as being hit with a 2x4, or the thunderclap part of it, I think, is a reflection that sometimes people even hear a noise when that artery ruptures. So this is a very severe, often life-threatening condition that requires immediate intervention, which is not available in Casper. And so we need to get those patients to the ER, get them diagnosed as quickly as possible, but then get them on a life flight to Denver or Salt Lake City so they can get definitive treatment.
Would that be the equivalent of the Widowmaker?
Yeah,
Potentially?
I would say, yeah.
Okay, good to know. Let's see, we talked about all the different types of strokes. Let's go to our stroke protocol real quick. You guys got a copy there, and we'll just kind of go through this, and hopefully we're doing everything right. If not, we do have, obviously I'm sure you know, our medical director, Dr. Colgan, is open to changing these. He's looking into all of our current protocols, and we do have a process to recommend changes if we find anything that's totally wrong with it. But I think the big thing that it starts off with is the Cincinnati pre-hospital stroke screen. Mm-hmm. So that's our fast scale, and then I think under your guys' advisement, I would add the balance and the eye movement and make it be fast, so we don't miss those posterior strokes.
Yeah.
So identification number 1, check a blood glucose, rule that out. And then if positive symptoms, now this says less than 6 hours. Right. I know you were talking about 4.5 hours.
So the less than 6 hours is based on 2015 guidelines for mechanical thrombectomy up to 6 hours. The new standard of care is treatment up to 24 hours, so that should be
up to 24. Okay. I think that's a simple delete 24.
Yeah.
I bet you we can do that.
And that's really handy. You know, a lot of times we see people who go to bed fine and wake up with a stroke, and those are the patients that we've been able to help more with thrombectomies lately. So
for sure.
We're even close to being able to identify patients up to 9.5 hours who could get clotbuster medication. So the whole treatment scheme is evolving rapidly, and we're able to include more and more patients in the treatment profile. So that treating more patients as acute strokes within 24 hours is really the goal here.
Mm-hmm.
That's awesome. Now, I don't want to get too far down in the weeds on those time differences, but what has allowed us to move those times from 4.5 hours to 6 hours to 24 hours?
You want to take this one?
I think there's been a lot of just clinical trial data. There's a lot more resources lately. We've been using tenecteplase more in these kinds of patients, which give us a little more versatility in our treatment decisions. There's not a lot of studies published yet on exactly how and what we can do with it, but there's a lot more potential opening up.
So what was the whole limit or what was the whole reason for limiting it to like 4.5 hours originally? Like there was no benefit to treating, or did it actually cause worse side effects?
Yes. So the clinical trials included every patient with acute stroke, and we found that beyond the 4.5, well, initially beyond the 3-hour window, and then later with some minor exclusions like old age or diabetes, we were able to find that most patients benefit from treatment up to 4.5 hours. What changed was the development of advanced imaging protocols that give us a picture of brain function. In other words, how fast blood is moving in and out of large areas of the brain will help us identify subgroups of patients. We have vast people who lose brain cells more quickly than others, so fast responders and slow responders. And by using advanced imaging technology, we can identify those patients who still have significant amounts of brain that we could rescue if we did an intervention. And so this is the system we use here is called RAPID, and it's part of our CT protocol. So when we do the CT perfusion and CT angiogram, all that data gets sent up to a cloud-based computer system that uses AI technologies and fancy mathematical conversions to give us a picture of that person's brain and tell us whether they're still, how big their actual stroke is, and then how much brain is still at risk. And based on that, we can decide whether they're a good candidate for treatment beyond 3, 4.5, 6, or even up to 24 hours. And there's different reasons to include people in each of those different categories.
It's pretty incredible. You guys are getting good at this.
Yeah.
I want to ask what it was like 18 years ago when you started.
Yeah, well, it was easier because many fewer patients would call 911. Most of them, when they got there, were outside the 3-hour window, and so they weren't a candidate for anything. And we couldn't tell who would benefit and who wouldn't. So we gave TPA to anybody who had stroke symptoms of less than 24 hours, less than 3 hours, if they didn't have a hemorrhage. And then we would do a CTA, and then we would try to put a catheter next to a clot if we found one in the brain and put some TPA in the artery. But it hardly ever worked. We had only a couple of good outcomes. And what changed there is the development of technology called stent retrievers, which after decades of trying to prove benefit to these intravascular treatments, it was this device that changed everything. And those were the first clinical trials, and there was 5 of them ongoing at once from 2010 to 2015. And they all published within 4 months of each other, showing very dramatic benefit to treating patients up to, and now the times were all over the place, but it was 12, 16, or 24 hours, depending on which study you looked at. But basically pulling that clot out using the stent retriever was very effective, with the number needed to treat to see benefit of like 1.2. So really the most effective medical treatment that's ever been invented in terms of those trials.
That's awesome. So you've seen a lot of improvement.
Yeah, it's been very gratifying, and it gets more fun all the time to be involved in this work.
That's cool. So I think I can summarize this real quick.
Yep.
Again, we're pretty much to the bottom of the stroke protocol, honestly. So Cincinnati pre-hospital stroke screen, use the BFAST scale, and I would, then we start to rule out some things, so do our blood glucose. Notice down at the very bottom is where it says notify destination. I think that can be done pretty much anywhere in the protocol, and it probably should be done as soon as we suspect a stroke. And then other than that, if we've got those positive symptoms, limit time on scene, early notification, transport emergent, all stroke patients, I would assume, and get them to your guys' front door.
Right. Yeah, one piece that I don't see here, if it's in there, I can't find it quickly, is once you and the neurologist together have decided to activate code stroke, we need you to call the ER and tell the person on the other end to activate the code stroke, because there's this pager loop that goes out that needs to happen, and the neurologist isn't doing that. The neurologist is getting dressed and going to the hospital.
Okay. So 2 phone calls. Talk to the neurologist and then
call the ER in
make
a
sure
normal way
they
and
know.
say we're activating the
Yeah,
code
if
stroke.
it's a code
Awesome.
stroke, yes.
And both they and we will want to know your ETA as well.
Awesome. Any other questions on things on that protocol? I think that runs us through most of the protocol itself.
We did put together a standard script to follow that has been laminated. I know it's for sure it's in the WMC ambulances, but it's a document that we can share with you that kind of walks you through how we would recommend communicating with the neurologist, and so what we're looking for in terms of information in a certain order, and then what responses to expect from us. So our responsibility when you've given us a presentation is to say, let's activate code stroke. What's your ETA? And that's the end of that conversation with us. Or let's not activate code stroke, and then I want to tell you why. So I want to provide that real-time feedback about why, in my opinion, we don't need to treat this as an acute neurologic emergency, or yes, it's an emergency, but not the code stroke emergency. So my responsibility is to explain that succinctly so that you understand my reasoning, because we have found that if we just say no code stroke, everybody's left scratching. Well, it looks like a stroke to me. Why aren't we?
Yeah.
I want to tell you why. So if I don't tell you, ask me.
Well, that makes sense. Yeah. And typically it's Wyoming Medical Center that makes the call to the neurologist and the ER, but we do have some outlying stations that are a little further away, so the opportunity is there for us to make those calls for sure. So I think that would be a good resource.
Absolutely.
Sarah, if maybe you could just email me that conversation, and we'll put it out to our guys so that they at least know the general flow of.
I've had a number of phone calls from Fire over the years, and then of course we work with Mills and Evansville, and the same protocols in place for Yes, bar none, of course, but I was thinking and I'm blanking on the county names, but in Douglas and Gillette as well, so we have the same process in place with them, and work direct with their EMS providers.
I think that'd be useful.
And then we're trying to get this exactly the same protocol developed statewide, whether they're calling us or calling their local ER provider, doesn't matter. If we're part of the telestroke team, then we're the right people to be calling for pre-hospital notification. So that hasn't quite taken hold yet, but that's part of our mission lifeline stroke work, is to try to make this, what we're doing here in Detroit County, a standard statewide, have a statewide system of triage for acute stroke care, because not every patient should go to their local facility. Some patients should bypass and come direct to Casper or straight to Cheyenne or Salt Lake or Denver, wherever the nearest stroke facility is. If they're outside the window for clotbuster, but they look like a good candidate for mechanical thrombectomy, you shouldn't stop at your local ER for that.
Good to know.
Yeah, I'll send you that algorithm though, and maybe a few other things that I'm thinking about too.
We'll take whatever you got.
Mm-hmm.
I think honestly that's an incredible summary of strokes and how to recognize them, how to care for them. I did want to wrap that up just by asking, like, what are some of your guys' goals for the future of stroke care here in Natrona County, and how can we help?
By far and away, our biggest goal, and I think we all share this goal, is to get more people to call sooner. We still only see about 1 in 5 acute patients with stroke within a time frame where treatment is even possible. So 80% of people are not even getting close to getting treated. So continue to spread the word around the community as to how to recognize the signs and symptoms of stroke. Teach Be Fast wherever you're going, and then really, really, really pound the importance of calling 911, because that puts all the pieces in place to maximize the chance that they're going to get the right treatment at the right time.
Awesome. I think we can do that for you.
Yeah.
We'll do some public education. How are we looking on time?
Fine.
Did you guys have some more time? I had no idea how long that took. Because my watch is recording.
47 minutes.
Yeah. 47 minutes. So
I can do another 10 minutes or so.
if we've got, I think maybe it's best, I know I've got some seizure stuff on here, but I bet you that goes longer than 10 minutes. Maybe we just answer some of the questions that the guys sent to us. So at the very end of that page, and then kind of the top of the second page. The first specific question I got was actually on the second page, which is, what is serotonin syndrome? How do you identify it? And is there anything we can do for it in the field? Could be probably a 10-minute question by itself. But.
Not really, because I'm not an expert in that. It's a pretty rare problem, and it's not usually life-threatening, at least not in a super time-sensitive way. So what it is in general is patients who are taking combinations of medications that inhibit the reuptake of serotonin. So serotonin reuptake inhibitors, SSRIs, for example, along with other medications that either also do that, like certain headache medications, or medications that inhibit the metabolism of those drugs, so make your SSRI work stronger, can increase your risk of serotonin syndrome. Serotonin syndrome causes a variety of different symptoms, including delirium, confusion, fever, tremor, sweatiness, palpitations, tachycardia. It can, over time, become life-threatening if it's not recognized and treated, though in most cases it will dissipate if the medications are withdrawn. So if we recognize it and don't give more of the SSRI or whatever the offending agent is, generally with supportive care, those patients will improve. So I'm not sure that this is something that is important to recognize in the field, and I don't think there are, other than, somebody's got severe hyperthermia, you may want to treat that with cooling blankets or something like that. But outside of that, I don't know that there's a whole lot that has to be done in the field for this.
And the hyperthermia is a pretty late.
It is, yeah. Usually, if you're picking up somebody with a temperature of 106, they're in extremis anyway, and you're gonna beat feet to the hospital and not get a lot of care in the field.
Yeah. And I gotta be honest, some of what you said there went over my head, but just so
that's why I was smiling as the question was asked, because it's pretty complex.
Yeah. Is it a buildup of too much serotonin?
Yes.
Because of those meds, or you don't have enough? So it's a buildup of too much.
Yeah. So the serotonin, rather than being reabsorbed by the cells, continues to circulate in the blood, and then as more and more of it builds up, it starts to work not just at the brain cells where it was released, but it also starts to work on like baroreceptors and temperature receptors elsewhere in the body.
Gotcha. That makes more sense.
Okay.
Perfect. Thank you. What about spinal immobilization? And I know it's not necessarily something that we do frequently, but what are your thoughts on clearing C-spines?
So,
what are some questions we can ask to identify?
So honestly, that's definitely outside my area of expertise. That's usually a trauma-related question, and as a neurologist, I don't usually get involved in trauma care, so I wouldn't be able to provide expert advice on that.
Perfect. I know we've talked about it with Dr. Coleman a few times, so we'll touch base with him on that again.
And then one of our neurosurgeons too would be great to talk to about that.
For sure. Those were the two questions that I got sent. So do you guys have any other neurological emergencies that you would like to just briefly touch on? Maybe something that's going really well here in Casper, or something that needs a little bit of improvement?
I mean, I'd be happy to spend at least 5 minutes talking about seizures. I think that's by far for me at least, that's the second most important thing I do that happens in the emergency room in an area where I think we all could see some improvement. So, seizures are, I guess what I would say about seizure management is that we have a tendency as healthcareers in general to overreact to the situation and do extra treatment that isn't really necessary and may cause the patient harm. So I see quite a few folks coming into the ER having been sort of over-medicated with benzodiazepines and end up needing to be intubated when that probably wasn't necessary. So what I would like to get across is that a seizure lasting less than 2 or 3 minutes in and of itself is not a medical emergency, especially if the patient is known to have epilepsy and wasn't injured as a result of the seizure itself. And so I would never recommend giving benzodiazepines to somebody whose seizure is over with. So if they're somnolent and post-ictal and slumped over, they definitely don't need benzos. Giving them at that point will just make them more sleepy, more likely to be intubated. Now, if the patient has a second convulsive seizure before they woke up, then technically that meets the definition of status epilepticus, and maybe they could use benzos, but maybe not, and that it becomes a fairly complex decision as to how to manage it. So this is why we've developed a status epilepticus protocol, which I was starting to look at, and you guys have in place. It looks pretty similar to what we have. So status epilepticus, a definition you can use for that is convulsive seizure lasting more than 5 minutes. So not just a staring spell. If the patient's vitals are stable and they're not moving, leave them be. They're going to be okay. If they're rigid and tonic and diaphoretic and their heart is pounding out of their chest, and it's been going on for more than 3 to 5 minutes, then yes, you should give them benzos and treat it as status.
Does the other classic definition of multiple seizures without recovering also meet that definition?
It does, but the time interval between one seizure and the next is 20 minutes, which shouldn't really pertain to acute care in the field.
Okay.
Hopefully you guys won't have the patients for 20 minutes.
Right. That's what I was
Probably
thinking.
not.
That second seizure should.
But if we do see multiple seizures in our time setting, 15 minutes, that obviously
that sounds like status too. But it would depend on the intensity of the seizure. So if it's not at all uncommon for a person to have a second smaller seizure, kind of an aftershock to the first seizure. And that can happen, 5, 10, 15 minutes later. And if it's brief, 10 seconds or something like that, I would probably just let that one ride.
From a clinician perspective too, seizures are one of the hardest things because you feel really, really helpless sitting there watching, and that's okay, and that's a feeling that as a nurse I had to get used to. So it's very uncomfortable, but a lot of times it's observation.
I mean, I've seen hundreds of seizures. Mm-hmm. They still make me feel sick when I watch them. But I've learned to sort of also remember intellectually, most seizures are not emergencies. People with epilepsy have seizures. If they're not injured by it, you probably don't need to do much other than, get them on their side so that they're less likely to aspirate. Remember not to put anything in the mouth during the convulsive part of the seizure. It's fine to put an oxygen mask on them when it's over, but wait until it's over so you're not pushing things back down in their throat. but really that's about it. And then so an issue that comes up a lot for your EMS providers is whether or not to transport, because a patient with epilepsy often will wake up and say, I don't want to go by ambulance, and that's honestly okay. If they know they have epilepsy and they've had a breakthrough seizure, this is something that we can absolutely manage in the outpatient clinical setting, and doesn't need to be taken to the ER unless they were injured as a result. So,
Gotcha.
so if there's bleeding or broken bones, please take them to the ER. But if they wake up and say, I'm going to be okay, please don't take me, then I'm fine with that as their seizure doctor.
Oh yeah, awesome. I think just a real quick summary of our protocol. I think you did a great job there, but we basically have two different sides of it. Status or postictal. Postictal, as you mentioned, is all supportive care. So we're gonna check vitals. We can give glucose and whatnot based on blood sugar reading, but as you mentioned, supportive care. And then on the other side, the status, once we meet that definition of your multiple seizures or a seizure lasting longer than 5 minutes, we can't consider our benzos.
Yes.
Pretty straightforward.
Yep. And I might, it may be worthwhile for us as a team to sort of work to tighten up those dosing recommendations, or settle on a single drug that we're all going to use or something like that. But yeah.
Awesome. Awesome. Do you guys have anything else to add?
I don't think so.
Well, again, thank you guys very much for coming out today.
It's our pleasure.
I know it's going to be useful for our guys. I got a lot of information out of this, so
Good.
hopefully it's useful for you guys as well.
Cool. Well, my phone number is on these forms, so if you guys have any questions, give me a call.
Awesome. Sounds good. Thank you very much.
Yeah, I'd be happy to help with whatever or could get involved. So.
Well, yeah, we will stay in touch.